Dr. Ali. Yes, you have the control.
Yes.
Just
Yes.
scroll up and down. No need to press. Scroll only. Okay. Okay.
Okay.
This patient, 25 years old, presented with dyspnea, chest pain, mild fever.
Okay. I have been presented with axial CT images with IV contrast for a patient with history of dyspnea, chest pain, and fever. I will scroll quickly through the images and then I will come back to my observation. Okay. Okay. Now I will back to my observation. First of all, I noticed that there is filling defect noted within the right
Excellent.
main pulmonary artery that is representing pulmonary infarction. Also, I noticed that there
Infarction,
is pulmonary embolism, sorry,
embolism. Okay.
pulmonary embolism. Yes,
Okay.
pulmonary embolism.
Okay.
Second of all, I noticed that there is aneurysmal dilatation
Good.
noted within the left main pulmonary artery,
Good.
and then it showed complete occlusion.
Good.
I can see that there is also multiple bilateral bilateral hilar lymph node enlargement.
Good.
Also, there is a small mediastinal lymph node enlargement. There is no pericardial effusion. In my routine practice, I want to change this into the lung window.
Okay. You finished the slices till the last cut, correct?
Yes.
Okay. I'll give you. I'll give you.
Mm.
Okay. You can scroll. You
Yes.
can scroll. Okay.
Yeah. Regarding the lung, I can see that there is cavitary lesions seen within the left lung in multiple loops. Also, I can
Good.
see that there are multiple nodules noted within the right lung.
Good.
It's stop scrolled. Um,
No problem. I will continue. I'll continue it.
okay.
Okay. Okay.
Regarding the combination of the multiple cavitary lesion and pulmonary embolism,
Mm,
representing septic emboli or showering
excellent.
emboli. Uh, Also, in my routine practice, I want to see if there is any uh, right-sided heart strain or if there
Okay.
is any
Very
other.
good point. Very good point. Uh, till now, yes or
Yes,
no?
yes. Till now, yes, there is right-sided heart strain because I can see that the intraventricular septum is not bowing toward the right side. It is in the midline, so
More
most
or
likely
less.
represent.
Okay.
Yeah, yeah.
Good. Good point. Mm.
Uh,
What is the explanation of aneurysmal dilatation you mentioned at the left pulmonary artery?
It have two theories. It could be due to uh, underlying etiology that is caused secondary pulmonary artery aneurysm, uh, or it could be due to proximal dilatation before the occlusion. If the
Mm,
patient is now in case of tuberculosis, I am thinking about pulmonary embolism, pulmonary aneurysm that is caused by the tuberculosis.
you saw the lung window. Do you suggest tuberculosis as a primary etiology?
Yes, because it could be because of the cavitary lesion, but not all the
Cavitary.
features.
Okay. Okay. Cavitary lesions. Okay.
Mm.
And pulmonary nodules. 25 years
Nodules.
old patient. TB.
25 years?
Mm,
Not
no.
likely.
No other features, my friend. No tree
Other,
in bud, no
no treatment.
nodularity. Okay.
Yes, yes, yes,
No one write the answers, please. Okay. This exam.
yes.
Okay. So, what do you suspect as underlying etiology?
Underlying etiology, I'm thinking about septic emboli plus mucotic
Yes.
aneurysm.
Excellent. Yes. Mycotic aneurysm. Good. mycotic
Yes.
aneurysm, and this is septic emboli and inflammatory
Septic emboli,
lymph
yes.
nodes. So the history you want to ask about is
IV drug abuse.
excellent, my friend. Okay, this you see the first word in this patient. Okay,
Yes.
finalize your case, yeah, boss.
Yes, I have been presented with axial chest CT with IV contrast for a patient who is IV drug abuser, presented with filling defects in both main pulmonary arteries and left main pulmonary artery aneurysm with multiple cavitary lesion representing septic emboli. In this case, I will urgently confine my finding to the referral doctor and refer this patient into the pulmonary and vascular MDT team for management.
Good, good, good. Very good, my friend. Very good. So it was a starting of inflammatory or mycotic aneurysm. Other possibility may be pulmonary hypertension, by the way, but not significant here in this patient. Excellent,
Yes.
my friend. Very good. Septic pulmonary emboli or pulmonary embolism in general is a common exam case and very important. It's a safety point, either present per se or secondary to another condition. Mild dilatation. Yes, yes, we have mild dilatation. Okay, my friend. Now the next candidate, يا boss. Easy case. Okay. Who is the next candidate? Yeah.
Good afternoon.
Candidate 2, you asked for control.
I have asked for a control, yeah.
Okay. Okay. You can scroll. Don't press, don't click, just scroll. This patient presented with acute chest pain.
Okay, so this is a contrast CT chest of a patient who has presented with acute pain. And I can see that in the initial cut, there are some fat stranding around the ascending aorta, and also there is the crescentic, there are 2 lumens in the descending thoracic aorta. So I would be concerned about acute aortic syndrome in this case. And looking at, there is a flap, and looking at the complications associated with the acute dissection, going through all the vessels and the branches of the aorta. So it is the flap is extending into the left common iliac, and just at the termination of the common iliac, it stops.
Good.
And now coming back to the
Last cut. I will, you will lose marks. Take care. I know it's a routine, okay? But maybe iliac tortuosity. It will be reported, should be reported in your report. Iliac arteries tortuosity. So please don't forget till the last cut. Sorry for interruption. You can continue.
Okay, so far I can see that the iliac artery and their branches are opacified, and look at the right, yeah. And there is a wedge-shaped infarct in the right
Excellent.
renal,
Good.
right kidney, which is the right renal artery is arising from the false lumen and
Good.
resulting into the complication.
Very
And
good.
the rest of the
How can you differentiate? Just a minute, just a minute. Leave this cut, leave it to me. Yes. In this cut, for example, how can you differentiate the true lumen from the false lumen?
so true lumen is in the it is more lateral than the false lumen generally.
Okay. What else?
Um,
You're talking about general. I'm talking about local signs here in this image, for example, or this cut.
yes, and the opacification. So
Yes. Good. Hmm.
the be more opacified, and if it is expanding false lumen, then true lumen will be small, as in this case.
Good. So opacification and size. Okay, anything else?
I will also look at the upper extent of the
Good.
flap, and so okay, so it is after the left subclavian artery, so which will classify it as the type B dissection, and patient.
Are you sure? Last cut from both sides. Okay. Here. You saw the clue or no?
Yes. So there is
where it started, the start point.
the highest. So it will be in the, because there is a dissection flap extending to the right common carotid.
Good.
And so it will be a type A dissection.
Good.
This is the dissection flap. So patient would need a urgent cardiovascular opinion. I will inform the referring clinician that about the type A dissection and the associated complications, and urgent cardiovascular review and surgery.
So the final management will be
surgical.
Yes, very important. Thank you, my friend. I will take the control again. No, just leave it to me. Okay, I will stop. Yes. My friends, regarding, we have here multiple points to comment on. Remember, in the oral exam, the first thing is about observation, knowledge, clinical reasoning, and of course, management, safety, and finally, communication. Unfortunately, communication now is becoming more important. My friend, don't speak continuously. Speak continuously. Avoid long stop. Avoid long stop. Even if we have a multiple cuts, okay? As you started, okay, I'm presented with CT with contrast and. The main finding till now is the presence of intimal flap. You said to me in the descending aorta. What about ascending? Okay, so take a careful look. We have also here some intimal flap and mural thrombus. This is a thrombosis. The dissection may be patent lumen, may be thrombosed lumen, like mural hematoma. So definitely, it started in the ascending aorta. Okay, avoid long stop during assessment from the first cut till the last cut. Okay, in the exam, usually the cuts will be lower than in radiopedia. Okay, it's very important. Regarding this case, it's a very common exam case. Today, this is the most common exam case, either in Viva or long, or even short cases as a plain radiograph. How to proceed through this case? Now, let's revise. Okay, I will remove annotation. Okay. Aortic dissection is a part of acute aortic syndrome. The patient usually presented with acute chest pain. Differential of acute chest pain. In the exam, acute aortic syndrome is number one, but maybe spontaneous pneumothorax or other causes. We have three subtypes of acute aortic syndrome. Dissection is the main type. Intramural hematoma. Okay, I need here, of course, a pre-contrast study and penetrating ulcer. Any one of them, if affecting the ascending, it's a Stanford A, surgical treatment. Okay, anyone started after the termination of left subclavian, it's a Stanford B, management, medical, if non-complicated. If non-complicated. If complicated, like in this case, Okay, it's a surgical again, cardiovascular surgery. Okay, very important question here. How to differentiate between false and true lumen? False lumen tend to be larger, as in this case also, and the density will be lower density, darker. Okay, and some filaments and beaking sign. I think in our case, all signs are present. You see these filaments larger in size, darker, okay, and also the peak sign present. It's very important also to assess the complications. So during the assessment, during reporting, whether long or oral case, mention the start point and the end point. Here it started in the ascending and terminated at the very good, my friend. Yes, at the nearly bifurcation of left common iliac artery. Very good. So the start point and the end point. Complications and extent of the flap. Complications here, very important to mention if there is a mediastinal hematoma or no. It's pertinent negative. You didn't mention this point, okay? So no significant mediastinal hematoma, no significant pleural effusion or pericardial effusion. It's a local complications in the chest. What about other complications regarding the extension? Here, very good. You detected infarctions. And generally, you should assess which vessel arising from the false and which vessel arising from the true lumen should be reported also. Here, for example, celiac, superior mesenteric, and left renal, all arising from the true lumen, while the right renal, which complicated later on, arising from the false lumen. So it's very important to mention this point. Cranial extension. The flap extended into brachiocephalic and into the carotid. So we may necessitate extended study also, CT, for example, on the cerebral vessels. Okay, if the because I'm suspecting, but I think here it's ended. Okay, so generally, my friends, because it's a very, very important case, you have to be systematic in this case. You should take full mark in this case. It's very common. I don't need any mark to be lost from you. Determine the site of origin and determination, okay, entry and re-entry, because it will determine the type, stand for the A or B, and the management accordingly. Surgical, here medical, controlling the hypertension, okay, plus surgical if complicated, as in this case. Which branches from each lumen and how to differentiate? This is a question from the examiner, most likely. Iliac tortuosity, if present, it may affect the route of management, so it should be mentioned. The last cuts, okay? Any organ at rest or complications, like renal, it's common, renal infarctions and hemorrhage, mediastinal hematoma, pleural, pericardial, and so on. Okay, well done, my friend. Well done. Now to the next candidate.
Candidate 4.
Yes, sir.
Okay, ask for control, my friend.
Sir, 1 second.
Okay, I will give you. Okay,
Requested.
okay, okay. This is just one image you can comment on. Then I'll give you the CT cuts. This patient has some chest pain, dyspnea after dialysis session. What do you see?
Okay. So I've been provided with scout images of the chest and upper abdomen, and I can see that there is a central venous line, which is being
Please,
inserted from the
can
left
you
side.
raise your voice little?
Yes, sir. Can you hear me?
Yes, yes.
Okay. So I've been provided with scout images of the chest and abdomen, in which I can see that there is a central venous line on the
Good.
left side, which is seen, tip is seen at the level of cavoatrial junction, so it is appropriately positioned. I can see that there are some lucencies which are outlining the cardiomediastinal outline. So this could represent pneumomediastinum. However, in scout images, sometimes the MAC effect is quite prominent. I can also see that there is slight depression of the right hemidiaphragm. Since this is likely taken in the supine position, I would also
Good.
be concerned about pneumothorax on the right side. I can see that there is an opacity projected towards the right side of the midline with a sharp margin laterally against the lung parenchyma, and medially it is merging with the mediastinum.
Good.
The
Show
hilar
me.
vessel,
Use the mouse. Use the mouse. Show me.
so this one,
Because you suspected pneumodiastinum, suspected pneumothorax, but not definitive, but suspected. Okay.
yes.
But where is the opacity?
So this one,
Okay, just one click. Use one click, then move the mouse. Yes,
sorry. So
yes.
this one,
Good, good. Can you describe it more?
yes, sir. So the opacity, I can see that the hilar vessels are seen through it. So the hilum
Good,
overlay sign is positive. It is
good,
either anterior or posterior. It is merging with the cardiac outline. So I'm suspecting this is an anterior mediastinal pathology. I also do not see any significant ribs playing or any
good.
rib deformity. There is no differential density within this opacity, such as calcification or any fluid level. So this is most likely an anterior mediastinal mass in an adult patient. The differentials would include a thymic epithelial lesion or a lymphomatic
Very
fluid
good,
in
my friend.
lymphoma.
You localize it, okay? But please take care about the given history. You remember the history?
Yes, sir. The patient has dialysis.
Dialysis, after dialysis, some chest pain and dyspnea. So
Sir.
we are looking for acute insult,
So
not
this could
a
also,
mass, okay?
sir, sir, sir.
Good.
So this could represent mediastinal hematoma as well from
Excellent.
damage to some of the vessels in the anterior mediastinum.
Good.
So I would suggest further evaluation with contrast enhanced CT scan chest.
Good. 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 Very good start. You localize it as anterior mediastinal, okay? Then I'll give you the contrast study. No, this study first. You can just one click, then scroll.
Okay, sir. I have been provided with axial non-contrast CT scan chest. I am scrolling through the images. I will first scroll through the entire stack of images and then I will comment on the findings. So it is also going down into the abdomen. So this is the last cut available.
Good.
So I can see that there is bilateral pleural effusions. There is increased density in the mediastinum with fat stranding, predominantly in the anterior mediastinum. And this has a density which is most likely similar to the vascular density. So this could represent a hematoma, mediastinal
Good.
hematoma. I can also see that I would be concerned about the dialysis catheter tip, whether it is extending beyond the confines of the vessel.
Good.
So over
Good.
here, it is
Good.
not extending into the vessel; it is outside. So maybe it has pierced some vessel, which has
Very good. How
resulted
to
in a
confirm
mediastinal
with
hematoma.
with
Post
with
contrast studies.
okay, I'll give you now the contrast study. You can scroll again from the start. Okay.
Okay.
One
So
click. Okay. Go.
yes, sir. So I can see that the catheter has been inserted by the left subclave internal jugular vein, and then it has
Good.
pierced beyond its margin wall, and it is extending into the mediastinum. So this is a venous injury, and there
Excellent.
has been extravasation of blood into the mediastinum, and there is also bilateral pleural effusion. I would like to go down to see if there is anything abnormal in the upper abdomen. Apart from the atherosclerotic changes, I do not see any significant abnormality. This hyperdense structure is,
Maybe
I don't
just
understand.
the gallbladder. It's
Yes,
okay.
gallbladder. Yes,
Okay.
sir. So
Okay.
this is a surgical emergency. I will immediately inform the referring physician. I would suggest the ER team to retract the catheter, and a vascular surgeon should be consulted for further management of this perforation.
Good, my friend. Very good. Very good.
Thank you.
So no need for lung window or bone window.
Sir, I will in my routine practice look at the lung and bone
Yes,
window after
yes.
I have conveyed my
Okay,
findings to the
very
referring
good.
physician.
I want these words to be يعني in your mind.
Yes, sir.
Okay, any case. Okay, I know it's a single pathology, but maybe double pathology, maybe related
Yes, sir.
pathology in the lung window. For example, this case, the same case. What do you see?
So I can see that there is a nodular opacity in the lung parenchyma on the right side, likely
Good,
in the middle lobe. It has spiculated margins.
excellent.
So I will be concerned this could represent a malignant nodule, and I would
Yes,
suggest cancer alert. I will put a cancer alert. I would suggest
good,
further imaging management and
good, good,
discussion
good.
at lung cancer MDT.
Very good, my friend. Very good. We have here some lessons. One of them is complete your study. I know you detected the diagnosis from the mediastinal window, but please just mention in my routine practice, I will do lung and bone window. Every case, finalize it like this. Okay? From the start, you did يعني very good, my friend, mashallah. You caught the main pathology. You describe it well. Okay? But correlation with the history. I give you a history. The history given by the examiner is very important. Okay, this is dialysis patient, but presenting acutely. Not every case with dialysis need a CT scan. I know here some blunting of the angle and here also, so we have to put a possibility of effusion. Okay, with the mediastinal hematoma, it can have also bilateral hemothorax. Okay,
Yes.
very good, my friend. And localizing it as anterior mediastinal, it's good. Okay, maybe يعني fused with the cardiac border on each side. It's separable from the aortic arch, which and the ascending aorta, which is posterior mediastinal structure. So it's most likely anterior mediastinal in origin. Okay. And regarding the CT scan, very good to assess the course of the catheter from the internal jugular, left brachiocephalic, then pierced or pierced here outside the vessel. So it leads to mediastinal hematoma. Any case, remember, my friends, any case, silhouetting both heart mediastinal hematoma here and also associated with effusion. Okay, so multiple silhouetting could be seen on radiograph. Any case, my friends, with a mediastinal hematoma, with a hemobritonium, with a hemothorax, please, we should comment on.
IVC.
Yes. Is IVC normal caliber or flattened? Later on the in my routine practice, I will assess other phases like
Yes.
venous or delayed. If hyper enhancing persistent renal enhancement, hyper enhancing adrenal, and so on. It's very important to rule out shock syndrome. Patient is bleeding. Okay.
Yes.
But generally, you did it well. Thank you, my friend.
Thank you.
Thank you, ya boss. So mediastinal enlargement in the acute setting, it can be of aortic etiology, it can be of venous etiology, like in this case. Okay, the next candidate, yes, that's the easy case. Who is the lucky?
Good evening, sir.
Good evening. How are you, my friend?
I'm fine, sir. Fine.
Okay, you are the lucky one. This is very easy case and straightforward. Ask for control.
Sir, can you please give me the control, sir? I'm not able to.
Okay, I'll see your. Okay, I will look for you candidate 5, but now, just comment on the plain radiograph. Trauma, middle-age patient.
Okay, I've been presented with a frontal radiograph of a chest image of a middle-aged patient. I'm saying there is an increased opacity noted in the.
Yes, you have the control now. Okay, don't
Yeah.
click. Just and use it without
Yes,
clicking.
sir.
Okay, okay.
Yes. Uh, I'm saying there is increased opacity noted in the left hemithorax, with obscuring the causing mediastinal shift towards the
Good.
right side, and there is the right lung field appear normal, There is also widening of the superior mediastinal shadow noted.
Good.
There is no blunting of bilateral CP angles. There is no obvious pneumothorax noted.
Good.
And visualized bones and ribs appears normal. There's no obvious fractures noted. So there is, summarizing my findings, there is widening of mostly superior mediastinum with the diffuse opacity along the left hemithorax. With
Good.
So this could be with the history of trauma. I would be suspecting mediastinal injury, any major vessel injury. Along with that, there might be a pleural effusion causing a homogeneous increased
Excellent.
opacity in the left lung, left hemithorax. So I would go ahead, recommend CCT thorax to rule out any aortic major vessel injuries and
Very good,
correlate
very
with
good. If this is a short reporting, okay, a short reporting style, you did it very well, my friend. We have a superior mediastinal widening, and we have a significant mass effect, mediastinal shift to the right side, tracheal shift to the left side, and depression of the left main
Yes, sir.
bronchus. It has this is part of the mass effect. Okay, what else?
Yes.
Inconspicuous aortic arch. I don't see the aortic arch. This is important point to be mentioned.
Yes.
Okay? Aortic arch is not seen. So this mediastinal thickening could be mediastinal hematoma of aortic pathology. Okay,
Yes.
very good, my friend. Veiling of the left lung field could be related to hemothorax as the patient is supine. It's fluid spread posterior to the lung. Some opacification of the upper lung part or lung apex that could represent a sign named, if opacified lung apex in the case of trauma, we have a sign. What is the name of this sign?
I'm not sure, sir.
No problem, no problem. Yes. Okay.
Yes.
Pleural cap, yes. Pleural
Yes,
cap sign.
pleural
Very
cap.
good, my friend.
Yes.
And
Yes.
very important to mention pertinent negatives. I'm dealing now with a case like a short report. What is pertinent negative? You mentioned no definite rib fracture because CT scan is
Yes.
superior, and also
Yes, sir.
intact hemidiaphragm. It's
Yes, sir.
important in the
Okay.
clinical setting. So fractures and hemidiaphragm. Okay, now you suspected mediastinal hematoma and you asked for contrast enhanced CT scan and also urgent
Yes.
cardiovascular assessment. For short reporting, we should
Okay.
also indicate this. Okay, I'll give you now the contrast. Just one click and scroll.
I've been provided with the
No click.
contrast.
Just scroll without click.
Yes.
Okay.
I've been
Scroll,
I'll
scroll,
scroll.
scroll. Yes.
I've been provided with the contrast enhanced axial CT images of uh, chest in arterial phase images. So I'm not. So can you please?
By the way, technical issues can occur in the exam. You have to
Yes.
stay calm. These nowadays, unfortunately, it's common occurrence.
Yes.
So you have to stay calm and tell the examiner, and after the exam, mention in incidental report, and try protect
Yes, sir.
your rights. Okay.
Okay. Yes, sir.
I will help you. I will help you. It's okay.
Yes, sir.
I will help you. No problem. Okay, just say I'm presented with.
I've been provided with the contrast enhanced axial CT images in arterial phase. I would like to see the entire stack of images and then comment on my findings. So I'm able to see there is hyperdense collection noted within the mediastinum with the there is hyperdense collection noted within the mediastinum, and there is active extravasation of contrast noted from the arch of aorta into the middle mediastinum. Uh, with wall irregularity and
Good.
aneurysmal dilatation of the thoracic aorta noted. There is moderate.
Aneurysmal dilatation. You mentioned extravasation and aneurysmal dilatation. Which one are you sure about?
It's aneurysmal dilatation.
So this part, this is aorta itself, or this one only?
Okay, so it is an extravasation. It's
Yes,
a
yes.
active
How to be sure?
it's
How
active.
to be sure? My routine
Way,
practice, I will.
yes.
Huh?
I will see for the plain images. I mean,
And
non-contrast
yes,
images.
no. Here to be sure, other planes. It's simply
Yes.
okay. Okay, my friend.
Okay.
What you
Yes,
see
sir.
here
Yes, sir.
from this plane?
There is a so there is a circular
Good.
aneurysmal dilatation noted in the posterior aspect of the descending aorta, extending into the arch, uh, and the wall of the aneurysm appears irregular. However, there is hyperdense collection noted around the around the aneurysm, but however, there is no active extravasation noted at the aneurysmal site.
So this is not active, and this not, and this not. Actually, this is not aneurysm. In the setting of trauma,
Okay.
if you see a focal dilatation with irregularity, okay, we call it aneurysm, or
Yes, sir.
we call it what? Hmm?
Pseudoaneurysm or
Yes,
yes,
pseudo aneurysm. It's
yes,
not
sir.
a true
Pseudoaneurysm.
aneurysm. It's a pseudo aneurysm. Very
Yes,
good.
sir.
So it's active excavation, yes, and the pseudo aneurysm formation, yes, and here the wall
Yes, sir.
irregularity, and this is a focal defect. Very good.
Yes,
Associated
sir.
with and with. Hmm?
Mediastinal hematoma and hematoma in the left hemisphere and left pleural space. Uh, and
Good.
there is, I would also like to see in my routine practice, I would like to see a lung window to rule out any pneumothorax
Excellent.
as there is
Yes.
history of trauma.
Yes.
I would
Good.
also
And
see this stacks of abdominal images.
excellent. And also bone window. Bone window for any fractures.
Bone window for any.
Okay.
Yes,
What
sir.
is the need for abdomen here?
Abdomen again. There is. I have to comment to see for any abdominal collection or a
Good.
pneumoperitoneum, and pneumo and hemoperitoneum also to be ruled out with the history of
Is
trauma,
it optimum
and
to
also
assess the abdomen in arterial phase?
no sir, venous phase to see
Okay.
for.
Hmm? Yes, to
I
see for
mean, as
what?
there is to see as there is hematoactive bleed within the
Hmm?
thorax, to see for IVC if there is
Excellent.
any collapse
Yes, any signs
and
of
to rule out
shock
any.
syndrome and any associated
Yes, sir.
injuries. Excellent, my friend. Excellent.
Yes,
Very good. Very good.
yes.
So finalize your case.
So so it's a case of with a history of trauma, middle-aged patient. There is a pseudoaneurysm in the thoracic aorta with active contra-extravasation noted, causing hemomediastinum with hemothorax with left hemithorax. So I would like to, with no pneumothorax and
Good.
no
Good.
obvious fractures. So I would urgently red flag the report and escalate my findings to the referring clinician and neurovascular surgeon for further management of the case.
Cardiovascular team for urgent
Cardiovascular.
surgical intervention.
Yes, sir.
Yes, it's a traumatic aortic rupture. Okay, it's traumatic
Yes,
aortic rupture, pseudoaneurysm formation, mediastinal hematoma, and left
yes, sir.
hemothorax, urgent cardiovascular surgery. Excellent, my friend. This is another
Yes.
case which is very important, by the way, for long, short, oral, but especially for short
Yes.
reporting. So again, mediastinal mass in the acute setting could be mediastinal hematoma, either of aortic etiology or of venous etiology. Well done, my friend. Well done. Thank you,
Yes.
Abbas. Thank you.